Today I will be discussing Internal Medicine Competency 1.10 History Taking in Heart Failure. So we'll start with what is the aim of the topic? To recognize the classical and atypical symptoms of heart failure and differentiate right heart failure, left heart failure. So let us look into what are the major symptoms of heart failure. The major symptoms of heart failure can be, first and foremost, is exertional dyspnea. Second symptom is fatigue, undue fatigue. Third major symptom is fluid retention. So these are the major symptoms of heart failure. The dyspnea can be, initially it can be exertional dyspnea, then it will go into, patient may need one or two pillows for nighttime sleep, otherwise called orthopnea. Episodes of paroxysmal nocturnal dyspnea can occur. PND. A properly elicited history of PND is pathognomonic of left heart failure. So here the patient goes to sleep. After 2 or 3 hours, the patient gets up due to breathlessness. They may cough 1 or 2 times or a few times. The breathlessness comes down. They may go to the window and pant for breath. The symptoms subside and they are able to go back to sleep. And usually that symptom doesn't repeat. So that is a typical history of paroxysmal nocturnal dyspnea. Again, point number 1 to be remembered is, if a patient is already having orthopnea or already having breathlessness and lying down or when they go to sleep, such a patient getting up at night cannot be called as paroxysmal nocturnal dyspnea. Remember, orthopnea is a sensitive indicator of left ventricular filling pressure. So that is one point to remember. That is orthopnea is a very sensitive indicator of ventricular filling pressure. And we know the mechanism of breathlessness in heart failure. When the heart fails as a pump, the end diastolic volume is increasing because the ventricle is unable to pump the blood. So what will happen? Back pressure, the left atrial pressure increases. That is transmitted to the pulmonary veins which are connected to the left atrium. So what happens? The lungs get congested, and as per the Starling's law, fluid translates in the tissues, lung gets interstitial edema and pulmonary edema later, alveolar edema. So this is what you remember, that is dyspnea in heart failure is due to pulmonary venous congestion that produces interstitial edema and pulmonary edema. Now we go to fatigue and reduced effort tolerance. This is very common in heart failure, but often that is missed. It is again an early symptom of heart failure, but often underreported. So what you should ask whether, compared to last 6 months, what is your effort tolerance? Because a patient with significant effort intolerance and fatigue may not report the symptom. They may still say, I am okay. So the patient might be as a manual labor, they might have stopped working because of breathlessness and fatigue, and now they are sedentary, and only when they are symptomatic at rest, usually they report that they are having symptoms. That is important to ask whether, compared to last 6 months, should ask about it. Then fluid retention. Fluid retention, the point to be remembered is that in heart failure, usually it is the dependent edema that is important. Abdominal distension can occur, but this is more common for liver disease. So the edema in heart failure is dependent edema, The pedal edema, the patient is walking around, so they have got the edema is more in the evening. So that is you should remember. And some days the complaint may be that the chapels are tight or the shoe is tight. Another point to remember is rapid weight gain. Again, it's an indicator of fluid retention. So the major symptoms you have mentioned. Then of course there can be other symptoms like palpitation, but these are the major symptoms that occurs during for a patient with heart failure. Now we go to one interactive question, a simple question to start with. A 56-year-old man wakes up gasping for breath 2 to 3 hours after sleep and feels relieved when sits up. The symptom is, we are all familiar, this is the typical paroxysmal nocturnal dyspnea. PND reflects redistribution of the interstitial fluid during sleeping, which leads on to pulmonary congestion. So the major contributing factor for PND or paroxysmal nocturnal dyspnea is the fluid redistribution. There are other factors like the decreased the respiratory drive that is occurring during sleep, diaphragm getting elevated. So these are, and the decreased sympathetic drive it is occurring. All these are contributing factors. But the major thing is redistribution of the fluid during sleeping. And again remember, the bronchoasthma usually occurs in the early hours of the night, not early hours, early morning, whereas in pulmonary edema, they usually in the first half, that is up to 2 to 3 hours of going to sleep. So remember, the symptoms are often non-specific and the severity of symptoms may not correlate correctly with the left ventricular function. So sometimes the symptoms may be poorly correlating. A patient with significant LV dysfunction may not be having much symptoms. That is what is meant by this statement. So we have studied about what is paroxysmal nocturnal dyspnea. Now we go into the next part of this competency. What are the precipitating factors and what are the exacerbating factors, and few points on the risk factors for heart failure. So the learning process usually focus on the reversible triggers and history with linked history with the etiology of heart failure. So common precipitating factors. So what are the common precipitating factors? So precipitating factor is a factor that led on to the present problem, that is the present episode of worsening heart failure or precipitation of heart failure. But the underlying cause is different. So here we are talking about the first precipitating factor. What is the most important precipitating factor? The most common precipitating factor of acute heart failure. Can you say? It is acute coronary syndrome. So the most important thing is acute coronary syndrome. Remember this point. Second is uncontrolled hypertension. Third is arrhythmias. Fourth, infections. And of course, in our setting, remember non-compliance. Non-compliance with the drugs is a very important point. Non-compliance. So these are the common precipitating factors. Okay, so what will you ask in the history? In the history, you should ask for whether the patient had got a recent fever, which indicates infection, any chest pain, that is suggestive of acute coronary syndrome, palpitation, that suggests of arrhythmias, drug non-compliance. And again, you should ask about drugs recently taken like NSAIDs, steroids, which can produce fluid retention, excess salt intake and fluid retention also. Or suppose somebody is restricted to have too much of fluid, or salt and fluid intake is also important point. So these are the points to be kept in mind. Now we go to the risk factors, or what are the causes of the underlying causes for heart failure. Again, remember the important things. First, remember hypertension is the most common cause, followed by diabetes. Diabetes may be due to diabetic cardiomyopathy, or patient may develop myocardial infarction. Coronary disease in third world countries, rheumatic heart disease, alcohol producing dilated cardiomyopathy, chemotherapy producing this anthracycline is producing cardiomyopathy, and family history of cardiomyopathy. So these are the underlying. So what are the most important? What are the major causes, precipitating causes? Hypertension, coronary disease, diabetes mellitus. In our place, remember the wild heart disease also. Of course, dilated cardiomyopathy. In cancer patients, remember about the chemotherapy, anthracyclines. Now we go to some one or two MCQs. Which of the following precipitate acute heart failure? What about NSAID? Yes, fluid retention. Atrial fibrillation, of course, arrhythmias. The turning point in life history of patient with especially with bilateral like mitral stenosis is the development of arrhythmias like AF. High salt intake, infection. Respiratory infection and urinary tract infection, these are the two infections which are notorious to precipitate. What about beta blocker? Beta blockers in smaller doses are being given for management of heart failure, but high dose of beta blockers can also produce heart failure. Why the infection produces heart failure or precipitate heart failure? It is because the infection produces increase in the metabolic demand. Increased salt intake, there is a volume expansion. So remember, beta blockers are one of the pillars for treatment of heart failure, but beta blockers can also precipitate heart failure. Up to 40 to 50% of heart failure admissions are preventable. So that is the importance of addressing the precipitation. So 50% of heart failure cases are preventable. That is a point to be remembered. Now we go to the third section on this. Competency, that is the exercise tolerance, sleep patterns, and assessment of the severity of heart failure. So first you think about the exercise tolerance. So this is the related to their functional capacity for exercise tolerance. Functional capacity is the single most important determinant of prognosis in heart failure. So functional, even though it is not the left ventricular ejection fraction, it is the functional capacity that determines the prognosis of the patient. So you should ask about how much distance they can walk, how much stairs they can climb, whether the daily activities are affected, and always compare with a baseline. Like 6 months back, what was this? In the previous session, we have classified the functional classes, NYHA classes we have discussed. So it is again, remember, it is a NYHA class, symptoms are classed. So class 1, no limitation of activity. Class 2, symptoms on ordinary activity. Class 3, minimal activity. And 4, symptoms at rest. For the detailed discussion, go back to the previous session. So just remember the four classes. Class 1, patient has got a heart disease, a problem, but they have got no symptoms, no limitation of activity. Class 4, they are symptomatic at rest. Class 3 means symptoms on minimal activity, and class 2, symptoms on ordinary activity. So easy to remember this. So we have discussed the importance of asking about the exercise tolerance and how the functionally class. Functional classification is mainly for the major cardiac symptoms like chest pain, not only for heart failure, for other symptoms also you can class. Like chest pain can be classed, breathlessness can be classed. Okay, that's the point to be remembered. Now we'll be going to the sleep patterns. What happens to sleep pattern? Already I mentioned, patient can develop orthopnea, they can develop paroxysmal nocturnal dyspnea. Nocturia is an important symptom. So what is the reason for nocturia that occurs in heart failure? It is due to decreased renal perfusion. Nocturia is often an early and overlooked symptom of heart failure. So remember this point, nocturia is an early and often overlooked symptom of heart failure. Now we go to an MCQ. So an assertion reason like nocturia is a common in heart failure. The reason, supine position improves renal blood flow at night. Assertion is correct. Nocturia is common. Supine position improves renal blood flow at night. So what do you think? Assertion is definitely correct. Reason, a patient with heart failure, when they are lying down, renal perfusion improves, and probably that is the reason for the nocturia that occurs in heart failure. So the correct answer is A. Then you may just think about this case. A patient can walk only 50 meters before stopping due to breathlessness, but is comfortable at rest. What is the functional class? So what is the functional class? So a patient is not symptomatic at rest, so it is not class 4. It is ordinary activities, it's only 50 meters, so it is less than ordinary activities, so this is class 3 symptoms. Hope this is clear to you. Now we will be moving on to the last part of this competency, that is the features suggestive of infective endocarditis. Because one of the precipitating factor of heart failure, we have said infection. We have mainly discussed about the systemic infection. Infective endocarditis can also precipitate heart failure. So why infective endocarditis matters? Heart failure is the most common cause of death in infective endocarditis. So that is why in this competency we are including the infective endocarditis also. What are the historical clues to infective endocarditis? Of course, a patient with a valvular disease coming with a prolonged fever, always remember infective endocarditis, subacute infective endocarditis. So the valvular lesions like mitral regurgitation may not be symptomatic, and so you should think about in any prolonged fever, think about infective endocarditis. Night sweats, weight loss, recent dental procedures, especially in patients with valvular disease, IV drug use, prosthetic valves, previous history of rheumatic fever. So that is the most important red flag. So somebody with a previous history of valvular disease coming with fever, always think about. Then what are the symptoms which is suggestive of valve involvement? So the patient can develop a papillary muscle dysfunction, rupture of the papillae. So that is leading on to regurgitations. So what are the symptoms? One is sudden worsening of dyspnea. For example, a patient has got a develop an acute mitral regurgitation because of the papillary muscle dysfunction or rupture, or an aortic valve acute regurgitation. So that is one of the complications that you get in. You can get a acute AR, and the valve becomes dysfunctional. So what happens? The left ventricle is unable to adjust with when there is an acute MR, the blood is ejected, it will come back to left ventricle, or somebody has got aortic regurgitation, the blood will come back to left ventricle. Left ventricle is unable to accommodate this, so the patient will be developing a rise in end diastolic volume pressure, that will be back pressure will be affected, the transmitted to the left atrium, that as mentioned earlier, that is transmitted to the lungs, and the lungs develops congestion. So now on examination you may get a new murmur, appearance, change in the quality of murmur, etc. But here we are mainly discussing about the symptoms. Hope. So infective endocarditis should be discussed or considered in any patient with a prolonged fever, especially when there is a underlying heart disease. So as per the Braunwald, Acute valvular regurgitation due to endocarditis presents with a rapidly progressive heart failure. And the major symptom of rapid heart failure is dyspnea. A 28-year-old man with a non-rheumatic heart disease patient presents with a fever of 3 weeks and sudden worsening of dyspnea, most likely diagnosis. Say 28 years, then no. So, what is the correct answer? In the particular setting, acute rheumatic fever, usually the presentation is with joint pain, fever, etc. That is not suggestive. Viral myocarditis, of course, is possible, but here it is 3 weeks, so it's not low in the list. Pulmonary embolism, again, usually the can present like this, but unlikely. The most appropriate answer is infective myocarditis. So remember this, the chronic fever or with valvular disease, heart failure, until proven otherwise, is infective endocarditis. So that's the take home message. Among the infective endocarditis, any patient with a valvular lesion coming with fever, symptoms of heart failure, unless proven otherwise, it is infective endocarditis. So I will close with the quote. Failure to elicit a proper history is more dangerous than failure to interpret an investigation. So keep this in your mind. This is a statement by William Osler. Failure to elicit proper history is more dangerous than failure to interpret an investigation. So I have completed the competency. Internal Medicine 1.10. Stay tuned for further videos. Thank you.